Good morning, Daniel. Thank you so much for taking the time to come on and chat with me. I'm super excited to have you on, so welcome.
Thanks for welcoming me. I appreciate it. I'm excited to speak with you.
Awesome. Yeah, like we talked a little bit before, I'm really excited to have you on today, especially because some of the stuff we're going to be talking about, patients that you specialize in post-stroke. And people have probably heard me talk about this on the podcast before, but my father-in-law had a massive stroke back in March, and I watched some of the, speech sessions and got feedback from my husband and my brother-in-law, my mother when they were there. So I definitely have some questions for you. But before we get into all that nitty-gritty stuff, if you want to share with the listeners a little bit about yourself, how you made that transition from SLP to Myo.
Excellent. Sure. So yes, my background's in speech language pathology. I've been for the last 10 years working in inpatient rehab settings, hospital settings, working with adults, geriatric population, with post-stroke, specializing in post-stroke treatment for swallowing disorders, speech and language issues. So with that, lots of continuing education about evaluation and treatment of stroke. A few years ago, I've worked all through COVID, and anybody in the medical setting will tell you, if you were working nonstop through COVID, it was a big change in terms of like working with your patients and the atmosphere, and looking for a change. So a few years, maybe like 5 years ago, I was reading books like Breath by James Nestor and The Oxygen Advantage, and learned about breathing exercises, got really into that. So a few years ago, I took a myofunctional therapy course with my colleague now, Lauren Reinhold, who's an RDH, and she's been my mentor for the past few years. Switched from full-time in the medical setting to working at a clinic in Newark, Delaware, called the Center for Airway and Facial Development, and the Pain and Sleep Therapy Center, working with children and adults with like really complex issues. A lot of it's like unremediated speech issues, people with ongoing swallowing issues, dysphagia, as we would call it in the medical field. And working in this setting, kind of learning a lot about how Myo it impacts speech, breathing, and it's really opened up the doors for like more education. So now I'm Buteyko Breathing certified as well.
Woo!
Yeah, I'm all about breathing.
Yep,
But
I
they
love
call
it.
me in the office, I go by the nickname Mr.Myo, because I'm like trying to get the kids like really pumped up about doing the exercises.
Yeah, I mean, that's so important though, because especially, with myofunctional therapy, it's not something that you're going to get one session, 2 sessions and be all set. It's typically a program, and you're seeing these patients for an extended period of time. And I know for me, I get so many questions from other myofunctional therapists, like, what can I do to keep these kids motivated? So even if you want to talk a little bit about that, like, what are some things that you do to keep the kids engaged and want to learn about breathing and want to be better?
Oh, I take like all the credit from Patrick McCown. I mean, when I'm working with kids on breathing and doing Myo, talking about, hey, you want to be better at sports? This is a great way to be better at sports. You want to make your parents happy. Improving your breathing and your sleep is going to help with your attention and your focus in school, get you better grades. And then, everybody's got some sort of vainness to them. So cosmetic looks are also a big.
Definitely.
But when it comes to the kids, I mean, a lot of it's, sports, athletics, appeasing or thinking about like what motivates them, like
Yes.
asking them directly, hey, do you like video games? Do you like basketball, soccer? And then just explaining to them how like improving your breathing and improving your sleep and your tongue posture, your overall body posture is going to help with like all of those aspects.
Now, I love that your mentor, tell me her first name again. Lauren?
Her name's Lauren.
Lauren, I thought so. Okay. I love that she comes from the RDH background. You come from the SLP world, and that you guys are working together. I love that, because there's things that go on in this field that unfortunately it's not always SLPs and RDHs working together. So can you talk a little bit about that and how, I'm sure it's so helpful for you guys coming from different aspects to be able to bounce different ideas and ask questions and things like that?
Oh, it's the past 2 years. I mean, I just kind of this continuing education all over again. All of these like symposium, these speech and airway symposium that we're going to is just like absorbing all of this new information and working with RDHs. And I'm learning so much about dentistry, things that I like, so she is teaching me this aspect of like abfraction, all these vocabulary words, that I just didn't know, all this stuff about teeth and like dentistry that I didn't know. And then my background in like working with people with swallowing issues, swallowing disorders, like the evaluation of that as well. And then like we just get to collaborate on speech and swallowing. She's always asking me about that. I'm always asking about like the palate size and airway size. So she's taken so many like Myo mentor courses with Dr. Zaghi, and she's part of the Airway circle. So she's all this great information and just, shares all of her knowledge as a myofunctional therapist with me.
Yeah, it's so incredible. I do definitely want to talk about so I know that you're not in the inpatient setting anymore, right? You're just completely outpatient now?
So I'm at Bay Health Medical Center. I work a PRN like per diem.
So how do you feel how have your evaluations, assessments of let's even if we want to categorize it post-stroke patients, how your assessments and evaluations have changed since getting that Myo training?
Well, as a speech language pathologist, like in the hospital setting, it's not changed significantly. I will say that I educate people a lot more on the importance of nasal breathing. And oral hygiene has always been a big aspect of speech language pathology in terms of like appropriate oral hygiene with clients who are like NPO or they can't have anything by mouth. Making sure that the oral cavity is clean. And that's something that's always been a part of speech therapy, because if you have like poor oral health and you were to aspirate or fluid were to get into your lungs, you're at a significantly higher risk of developing pneumonia or getting sick.
Right.
So that's been something that we've always done as speech therapists. I'm a little bit interested now, though. I'm doing a lot about nasal education with people and just like, are you able to breathe through your nose? I'm checking to see if they can breathe through each of their nostrils. I'm checking their lip posture at rest, and I'm making more notations about this and educating more staff about this, because a lot of people that I see unfortunately are untreated sleep apnea cases probably. In the inpatient rehab hospital that I was working at before, it's called Encompass Health in Middletown. They have 40 beds now. And they would probably have 30 people snoring out of the 40. Maybe 2 CPAPs in the hospital. It's just really concerning how the CPAPs don't make it from home to the hospital, from the hospital to the other hospital, things like that.
Yeah, totally. And, I know I was telling you about this before we started recording, but, to get back to my father-in-law with his stroke, he had his sleep test done as part of a research group when he was at the hospital in the very beginning. He had his stroke in March. So this was still in March. Came back positive. They had recommended CPAP therapy, but he soon after went to the rehab facility and he was there for 8 months. And then he went on to the second skilled nursing facility for another 2 months. He literally just came home the day after Christmas since March, still being untreated for his sleep apnea. And it is just so mind-blowing to me that this isn't something that is such a concern. Obviously you want their rehab to be a success. And if we think about what happens with sleep apnea, right? When you have that obstruction, when you're literally stopping to breathe, you are deprived of oxygen. How can that not impact your ability to rehab, or at least rehab better? and, you know, obviously I can only say so much. I mean, I'm the daughter-in-law. So it's, you know, we talk about even too, like working with family is hard. I mean, there's so much things as a myofunctional therapist that I've been wanting to even kind of try with my father-in-law, but it's tough. You know, I'm his daughter-in-law and here I am like, try to stick out your tongue, try to move it this way. Let's do this. Let's do that. He's like, sorry, Britt, no. And my father-in-law is nonverbal. So he's not speaking, you know, he's not walking, unfortunately. So it has been really tough, but I mean, I would even love to know like what types of, I don't know, exercises you would give to somebody post-stroke who is nonverbal.
That's so that's an interesting, I guess we'd start with the evaluation. So, I mean,
Yeah.
in the hospital setting, like an SLP is going to do a chart review, you know,
Mhm.
look at all of the background history, see what's going on, determine whether the orders are for like a speech evaluation or if it's a swallowing evaluation. That's normally how it goes in the hospital.
Mhm.
Or you'd have both. Um, and so you do a bedside swallowing evaluation. And that entails like, you know, you could do like a cranial nerve examination,
Okay.
whatever you're able to do with the 12 cranial nerves, and the assessment to take a look at how those are
Interesting.
functioning.
So that's something that's always part of your evaluations for stroke patients? Because I mean, I wasn't there for the speech evaluation, but I don't recall hearing anything about any kind of cranial nerve testing.
Yes. And that's where it gets like, you know, it's it's clinician specific. It's like,
Okay.
what is your training? Have you taken a course in cranial nerve examination? Are you familiar with doing it? I mean, most of the time it would probably be more of a screening, like
Okay.
what you would typically do in like your assessment, like a screening, and then you can go into more depth. Some
Okay.
clinicians will even treat based off of the results of a cranial nerve examination, like trying to treat the dysfunction, like the
Yep.
nerves. Um, so that could be a part of your evaluation. Bedside swallowing evaluation is an oral motor exam. What I've learned as a myofunctional therapist is I didn't understand anything about compensations as a speech language pathologist until a couple of years ago.
Mhm.
So if I had people sticking their tongue out side to side and their jaw was swaying, everything's good.
Right.
But I know that that's not the case now. Like compensations with other muscle groups. So that would be part. And then if you're looking at swallowing, a bedside swallowing evaluation would entail like different types of food or liquid.
Right.
When we're doing, now you were speaking more about language and speech.
Yeah, so he did, I mean, the swallowing test, he was on a feeding tube for a little bit. He's been off the feeding tube for a while. I want to say
Okay.
like since May, he's been off of it. So he was only on it for a little bit. I mean, it takes him a while to eat, but he's able to do it. So yeah, I mean, I guess we can talk about the dysphagia part after, but yeah, definitely more,
You're thinking more of the speech and the language aspect. Yeah.
because that, you know, it's crazy. Like, I mean, obviously you think, okay, he's not walking, he's not talking, which is worse. They're both horrible. And obviously selfishly, like we want to hear his, like it's so, the fact that like we haven't communicated with him verbally since March. I mean, it's so tough. And not, of course, that you would say, oh, I'd rather he speak than be able to walk. Of course not. But just if we could, you know, get him to a point where we'd be able to at least have more conversations with him. So yeah, I think I'm asking more speech related.
Yeah. So, like the hospital, like Bay Health Medical Center, I mean, we have like a speech and language screening thing that we've made you from different speech and language tests, kind of compiled together, yes and no questions, looking at pictures, identifying pictures. So all of these different things to look at receptive language, which is like your understanding, your expressive language, your ability to express yourself, your ideas. Speech is the articulation of the production of the actual sounds, looking at that as well. And then other aspects of cognition are kind of screened, not so much like treated, attention, short-term memory, long-term memory, orientation, time, place, situation, problem solving. You can kind of get more involved. But when it comes to like in your dad's case, trying to find out like the receptive language abilities. So you might go into more depth after a short screening. Let's say your father answers like 2 out of 5 yes and no questions correctly. Okay, that's a functional thing to work towards, is like, let's work on consistently answering yes and no questions appropriately.
Okay.
And treatment would involve like kind of modifying the vocabulary that you use, or maybe the language complexity, slowing down when speaking, to help him to understand better, maybe raising your voice.
Yep.
And then working with him towards improving his it's really helpful when receptive language is intact to work on expressive language.
Okay.
If a person's not understanding you, obviously this is like kind of a barrier towards working towards goals, but we have to meet people where they're at, just like with myotherapy, and kind of work towards that.
Very interesting. I mean, and I know it's because it's they're opposite sides of the brain, but you put a song on and he sings it. Every word. Of course, a song that he knows and he loves, and that he loved before, but like, and you can understand. I mean, of course, it's still not as articulate as he was before, but like, it's just crazy to me that like, just like that, he knows he can sing an entire song as soon as you put the melody on, or you start the melody.
That is interesting. When you get into a neurogenic stroke and it's language and speech, you'll hear these terms: aphasia, apraxia, dysarthria, and they can all kind of co-occur at the same time, which you have to do a differential diagnosis when you're like doing your assessment. There's different types of aphasia. Aphasia is an acquired language disorder. So you'll have like a receptive component and an expressive component. Based on what you're describing, like, it seems like volitional speaking is not intact, but automated speech is somewhat intact. And that's something that we would use in order to, like, as a cornerstone for his speech therapy. All right, so he's got these, like, he can count 1 to 10. He can say his ABCs. He can sing these songs. He can fill in the end of a blank, like ice is very cold, something like that. And just to work on getting that expressive output on a volitional standpoint rather than that automatic.
Right. Okay. Interesting. And what about, like, have you ever used Myo Munchies with your patients with stroke?
I have not. No, I've never used that in the hospital setting.
I just want to like literally hand one to him and see what he does with it, because he's eating, again, like I said, he's eating solids, but obviously softer things. So now, of course, I'm thinking like, oh my God, he hasn't been chewing, and we obviously know the importance of chewing. So, and even just the work that the munchie can do for him, I'd love to just give him one again, like I said, and see. So I was just I guess my question would be, do you think it would be beneficial? I mean, it can't be harmful.
I would agree with you there. I mean, the Myo Munchie is a great appliance to work on, like, lip closure, jaw strengthening. That comes down to like, what in your assessment or the speech therapist assessment, like, does he look like he has like an atrophy of those muscles because of the feeding tube, or because of like being in just hospitalized? So like, he would benefit from like conditioning of those muscles, strengthening lip closure. Yeah, definitely. Not in the hospital setting that I've done, but it's just definitely a great appliance.
Yeah, absolutely. And I'm sure when you're in that hospital setting, like, you're kind of held back with how much freedom you have to kind of incorporate more myo. I would assume, at least from what I hear from other speech therapists, when they're still working in more school-based settings and things like that, like you can only do so much.
Yeah, and that's kind of my goal now, I think, is I want to bridge this medical setting and this myofunctional therapy setting. So I live in Delaware, and Delaware is like, middle East Coast for people who aren't familiar. And there's not a lot of understanding of myofunctional therapy, not a lot of providers, and not a lot. I mean, part of what I want to do is, and what I have been doing, is educating like pediatricians, talking with past colleagues, speech therapists, the medical director at the previous hospital I was at, just talking with them about the benefits of myofunctional therapy and how I think every hospital should have one speech language pathologist who specialized in myofunctional therapy or has a background in that, because you bring so much more to the table when you do that, and when you collaborate and you work on things from a different perspective.
How have you found, so like speaking to the pediatricians and whatnot, do you come across issues ever where you're noticing, restricted lingual frenum, but pediatricians not agreeing with it? Or do you feel that they're being more open now that you're having these conversations with them?
Every once in a while you come across somebody who, or a person that you just need to speak with more about it. I think they don't know who you are, and they might not have gotten the whole picture. But in my recent experience, I've seen a lot of ENTs who've been very receptive to myofunctional therapy, because I like to kind of give this analogy of like a tree, in terms of like a way that you can treat if you're having sleep or breathing issues. And myofunctional therapy, nasal hygiene is at the very bottom of the tree. You can reach up really easily and just grab that apple, and then you're doing much better. The CPAP and other alternatives, you have to climb a ladder to get to it, and it's like not really that reinforcing. So I really think that educating people on just the small things that you can do, like therapy and nasal hygiene, or like ways that we can kind of garner more support for myo, because most ENTs just don't really know what myofunctional therapy is.
Now, do you find, so if you're treating, a kiddo with articulation issues, do you find that you do more myo first? As like, is that the underlying thing, and then you tackle the speech component, or is it like mixed in?
It's kind of mixed in. So some of the children that I'm working with, they've been referred by speech language pathologists, or they've been referred from people. And the reason why is like their speech maybe not be progressing. They've been doing speech therapy for this many years, and they still have these issues. So when that's the case, I'm probably not going to be working on speech with this child. The reason why they're not making progress is we need to identify that first. And then I think myo is like a really good foundation. I call like speech language therapy, to me, is like phase 3.
Interesting.
Phase 1 to me, breathing, jaw work, making sure that the nose is open. Phase 2 would be like lips, tongue mobility, range of motion. If you need to, tongue tie release, if that's like something that's on the table. And then after that, I mean, if phase 1 and phase 2 are going great, they can breathe through their nose, their jaw's stable, their lips are strong, their tongue is functioning better. Now we're working on speech and swallowing. We have all the skills that we need, all the barriers.
Laid all that foundation, all the foundation.
Exactly. Because otherwise I'm teaching people to compensate.
And
if in the hospital setting, working with adults, we're teaching people to compensate. It's helpful because we're teaching people to survive.
Of course.
But ultimately, when you're doing myo with a younger kid, you don't want this kid to survive. You want that kid to thrive and not end up in the situation that an adult would be potentially if they had an untreated issue.
Absolutely. And I'm really excited to bring up the next topic. You had wanted to discuss some research around sublingual varices and increased hypertension risk. If you want to first tell the audience what you mean about sublingual varices, because I'm not sure everybody will be familiar.
So this is something that my colleague, Dr. Joanna Green, she's an airway focused dentist. She brought up to me. She showed me this article months ago that it was talking about, it was from a dentistry journal, if you will. And it was talking about how when you have sublingual varices, or these veins, like very prominent veins underneath of your tongue, there is a certain degree of like, let's say hypertension, if you will. They can, dentists can determine if you're at like an increased risk for hypertension based on just looking underneath of your tongue. And I thought that that was really interesting because when they showed pictures of the tongue too, the first person had, let's say, like pre-hypertension. The second person was definitely confirmed hypertension. The other person had moderate. I was looking at the tongues and I saw that the range of motion was also really impaired in the person who was like moderate hypertension. And I thought, that can't just, maybe that's a correlation, but I want to look a little bit more into this because ultimately when it comes to a stroke, you can just be unlucky. There can be something that's, you know, congenital that it was going to happen at some point.
Right.
It can be a blood clot, like a COVID type of situation that contributes to it. But a lot of the strokes that we see are like ischemic strokes, like narrowing of the arteries, which that kind of points to just generally not good health, whether it be like diet, exercise, and sleep.
Absolutely.
So I'm interested in like the tongue range of motion and how dentists can help people to identify if they have hypertension.
There was a cardiologist at the AAPMD meeting this year in September who says that he takes tongue range of motion ratios on every single one of his cardiac patients. And I just thought that that was like the most amazing thing ever. I'm really actually hoping that the AAPMD has him as a speaker because I'd love to hear him speak. I mean, literally, we need that. We need, to your point, medical and dental need to come together. There is absolutely no reason that we should be separated. It doesn't even make sense. I mean, this is the gateway to your health, right? The mouth.
Exactly.
So I am totally with you on that, on the importance of just getting out there, spreading the word, increasing awareness, doing whatever we can to just get this information out to the masses. And to kind of bring it back to how you said you originally got into this, like reading the book Breath. I mean, there's so many patients that find us online, and usually that is what brings them to finding us online. They read Breath, and James Nestor, what he did for our field to help increase that awareness, you know, not coming as the actual healthcare provider in the field writing this book, but as somebody who has been through it himself, who, you know, like the study that he did where they plugged up his nose so they can study the impacts of mouth breathing. Like, it just did an incredible amount for our field. And I know all of us in this field are just so thankful to him for doing that.
It's always the stories like that really tell it. I mean, the book Breath is so good because it's a narrative, and he's just a great author, and just it's really easy to read. And then when you learn everything about that, again, you kind of like look into yourself and realize all your own dysfunctions or things that you're
even taking your first myo class, it's like, oh my God, that's me. I can't do that exercise. Look at my tongue. It's not going that far. It's crazy. It really, and that's, you know, I always tell all of our students, like, be your first patient, put yourself through a myofunctional therapy program before you try to put anybody else through it. You know, you want to obviously first be able to understand the exercises and be able to teach the correct way to do them. But myofunctional disorders are so prevalent. And it's funny because so I'm talking about the Team Myo course that I teach with Carice. When we start our course, we have like a pre-interview onboarding, whatever you want to call it, with the students. And the first question we ask is, do you think you have any OMDs? And a lot of times they'll be like, no, I don't think so, but my son or my this or my that. And then like by week 2 into the course, during our Q&A, they're like, you know what? I think I'm tongue-tied. You know what? I have a bunch mentalis. And it's so funny because, to your point, you hear these things and then you're looking inward and it's like, oh my God, that's me.
Yeah, the CBCT is like, or the cone beam CT scan is not utilized in the medical setting a lot. When I saw my CBCT, I was like really like mind blown. And I said, like, you know, if we had this in the hospital setting, I would have been able to identify a lot of the reasons why people were having issues with swallowing.
Yeah.
In the hospital setting, there's like, we talked a little bit about the bedside swallowing assessment, but there's two other main assessments that they use to assess swallowing. And I don't know if your father-in-law had this experience, but they do like a modified barium swallow test.
I don't think he had one of those, to be honest. It was just the bedside ones.
So that's a swallow test where they give you different consistencies of foods and liquids with barium in it. And then you're kind of in between an x-ray machine, and they do a video of you swallowing, and they show where the food or the liquid is going as you're chewing and swallowing it. So as a speech therapist, you're looking at the oral phase, how they're doing manipulating the food, the pharyngeal phase, like when they move the food back, they propel it down. And you're kind of even looking a little bit at the esophageal phase, whether food is coming back up or whether it's making its way down. And so that's an assessment that you use to track objectively what's going on with a person's swallow. And then another assessment would be the FEES, or the fiber optic endoscopic evaluation, which has they both have their advantages and disadvantages. But the FEES test,
I feel like he had that.
I
think he did.
It's a good test because, like, you don't have to transport a person like down to radiology. There's a lot less. You can actually keep the scope in there for an entire meal sometimes, depending on the person's tolerance. So you can assess their swallowing throughout the meal. Because, in the beginning of a meal, a person might be doing fine, but towards the end, they might be fatiguing. So the Myo Munchie would definitely help your father-in-law with that, keeping the lips.
And I feel like he so often, like, it takes him a very long time to chew, and then he's packing food, and it's like he wants to take the next bite, but it's like you have to finish chewing what's in your mouth, or it'll take him like 5 minutes to chew one bite. And that's where I'm thinking, like, the Myo Munchie, again, it can't be harmful, it's only going to help, but I'm assuming that that's probably also semi-normal for him at this point,
to be
like taking so long to chew. Like, is that pretty normal?
I would say so. I mean, the way that you kind of described how
I know it's hard for you. You've never evaluated or assessed my father-in-law, so I know it's hard for you to answer, but
yeah, bolus transfer tends to be something that, or like the chewing, the organizing of the bolus,
right,
and then moving it from the front to the back of the throat tends to be something that is like a barrier for people. Like organizing the bolus into, how we practice, like into a cohesive ball on the tongue. That's not something quite utilized in the medical setting. It's a lot of oral motor exercises to work on chewing and helping the person to, like, a lot of it's compensations and like helping people to modify diets, such as like the food a little bit easier to chew. But
now,
then,
what would be an example of like an oral motor exercise that you or somebody would do with somebody like my father-in-law? Because that's the part that I felt like was missing, at least when I went to watch his speech sessions. And I did try to go when I knew he was going to have them. A lot of it was just like, looking at a screen and like, which one's the B? You know what I mean? Point to the one, tap the one that is whatever that they're trying to get him to do, and not so much like any kind of oral motor work.
So that looks like a language, or like a language intervention. Yeah, when it comes to oral motor exercises, some of the oral motor exercises are similar to what a myofunctional therapist would do. A lot of the exercises prescribed, one of them is called the Masako maneuver. It's when you stick your tongue out, you try to bite down on it, and then you swallow while you're biting down.
Yes.
It causes you to recruit more of your pharyngeal muscles. So you would use that with a person who has demonstrated pharyngeal muscle weakness.
Right.
And you can see that on the swallow test, or you could just see that as they swallow, the food is still kind of stuck in the throat. It's not being pushed down. So that's like an exercise to strengthen the pharyngeal muscles. A lot of the tongue exercises would be similar. I've started incorporating tongue clicking into my speech sessions because that's really important for strength, toning. They have this cool device called the IOPE that is a little bulb that you put on the tongue, and each person gets their own, and you can actually measure the tongue strength as they press it against the palate.
Oh, so cool.
And it's really cool because you get that objective information before and after. So like if a person has cranial nerve dysfunctions affecting their 12th, their hypoglossal nerve, they're going to have tongue weakness. You'll get an initial reading. They press the bulb up. The pressure is like 4 pounds of pressure. And then, you know, you do these exercises with them, and you can use the IOP tool as the exercise.
Right.
And, you know, week 2 later, the goal is that the lingual strength and tone is increased. So that's a device that a speech therapist might use.
Interesting. I'm going to ask, I mean, he's getting speech home now, like once a week. So I'm going to have to, I haven't met the woman yet, but I will hopefully be able to meet her soon. Well, thank you for all of this. Today's actually my father-in-law's birthday. How funny is that, that you're on the podcast today? Today's his birthday. So we'll be going over there later. So maybe I won't do it to him on his birthday, but maybe tomorrow I'm going to pop one of the munchies in
Oh no, you froze.
there, start asking him to do different moves, or at least maybe I can just have the conversation with his speech therapist. Like, he really hasn't gotten any oral motor work. Is there things that we can be doing with him? And maybe even just, he'll probably respond better to her than he would to me. So even if I can just talk with her and explain to her where I'm coming at from my field, and even if she isn't familiar with Myo, give her some things that she could even just try with him.
That, you know, that sounds like great. In my experience in the hospitals, like speech therapists are going, they have a long list of clients that they have to see. They prioritize dysphagia a lot of the times.
Okay. That makes sense.
And when, yeah, you're in and out and you get to, you see a person for 15, 30 minutes, and then unfortunately it's on to the next swallow evaluation or treatment. There's not an inpatient, there's not a ton of, like in the actual hospital itself, lots of evaluation, less treatment. In like an inpatient rehab hospital where they're kind of medically stable enough to go somewhere to get like intensive therapy, that's when you tend to see like longer speech sessions, half an hour specifically working on speech language, and then the other half an hour or maybe even more time working on swallowing. And that's kind of like the ideal setting. If you like right after a stroke, the best time to intervene. Like the first 6 months, the most important time to intervene, because that's when all the healing occurs, right? And so to your point of what you were talking about earlier, how are we not emphasizing sleep and breathing after a person has a traumatic brain injury like that? It's there's so much research into post-stroke treatment, like supplementation, like IV perfusion, just IVs to get people hydrated post-stroke.
Yeah,
has been
awesome.
showing improvements. Supplementation, fish oils are really, or omega-3 oils, really big on helping people heal from TBI. There's just so much that I think the traditional medical setting is going to have to catch up with, because they're going to realize that people are making progress when they treat things in, you know, a more holistic manner and not just throwing medications at it.
Absolutely. 100%. This has been so great, Daniel. Thank you so much for taking the time out of your busy schedule to come and chat with us. Is there anything else you'd like to leave with your listeners before we wrap up? I definitely mention your social media handles. I do have it in they'll be at the beginning of the episode along with your bio, but if you want to leave everybody with where they can find you, that would be awesome.
Cool. Yeah, you can find me at Mr.Myo 302 on Instagram. I follow you. I've been following you pretty much since I opened up the account.
Oh, awesome. Thank you.
My goal is really to educate more people, just tell more people, kids, adults, about the benefits of myofunctional therapy. And in my free time, when I'm not treating, I want to get out. I want to talk with ENTs, pediatricians, speech therapists, occupational therapists. My partner is an occupational therapist. So it's like, eventually we're going to be like this feeding and speech and language like duo.
Oh, that's beautiful.
And I just want to plug our center in Newark, Delaware, the Center for Airway and Facial Development. We have myofunctional therapists, speech therapists, airway dentists, every service that you can imagine, growth appliances, tongue tie release, speech therapy, feeding therapy. And we're experienced with people coming to us when we're the last person that they come to. Like they've tried everything. And it's a really holistic and collaborative approach. And, you know, having the opportunity to speak with you and get us out there is really, really
absolutely. We'll put the link to your guys' website in your show notes along with your social media handles, so you guys will be able to go and check out that center. We need more centers like that all over, right? So thank you again, Daniel, so much, and we'll have to have you back again soon.
Awesome. Thanks for having me.